Hello and welcome to this Clinical Care Options Oncology podcast. I'm your host, Jerfis Constanzo. In today's episode, we're joined by Dr. Jessica Lin from the Massachusetts General Hospital and Dr. Alice Shaw from the Dana-Farber Cancer Institute in Boston, Massachusetts. Together, they will be discussing the role of ROS1 and ROS1 alterations in molecular testing in patients with advanced non-small cell lung cancer. This episode is part of a larger educational program entitled ROS1 Revealed, a cancer conversation on the changing tide of non-small cell lung cancer treatment. For more information on Drs. Lin and Shaw, along with a link to the complete program including downloadable slide sets and a clinical thought commentary, please visit the show notes for this episode. Now let's hear what the experts have to say on this topic.
So let's just dive right in. Here are the topics that I'm going to cover in this first section, starting with what's known about the normal or physiologic role of ROS1. The ROS1 gene resides on chromosome 6 and encodes an evolutionarily conserved receptor tyrosine kinase with still as yet uncertain function. Like other RTKs, ROS1 signals through canonical pathways, including the RAS-MAP kinase and PI3 kinase AKT pathways, among others. And these pathways promote a variety of different cellular processes. Now, in the context of lung cancer, we actually understand a lot more about ROS1. Chromosomal rearrangements of ROS1 leading to ROS1 fusions were first discovered back in 2007, and that's the same year when ALK rearrangements were discovered in lung cancer. ROS1 fusions are somewhat rare, found in 1 to 2% of non-small cell lung cancer patients, and similar to ALK, involve fusion of the intracellular kinase domain containing region of ROS1. To the N-terminal portion of a partner gene. And to date, as you can see here, many different ROS1 partner genes have been discovered, with the most common ones shown here on the left. This is from a review from Alex Drelon and colleagues at MSK. Importantly, this aberrant fusion leads to constitutive activation of the ROS1 kinase, and this drives downstream growth and survival pathways and leads to the state of ROS1 dependency, or what we commonly refer to as oncogene addiction. Jess, I was wondering, maybe before we move on, I was wondering if you wanted to share any thoughts on all of these different ROS1 partners and how they may or may not correlate with clinical outcomes, and maybe a word on how you might incorporate this information into your clinical practice, if at all.
Sure. Since the initial discovery of ROS1 fusions in lung cancer, we have found that there is a diverse spectrum of fusion gene partners for ROS1. And there has indeed been a lot of interest in trying to understand whether the distinct ROS1 fusion partners affect clinical outcomes. Thus far, there has not been any definitive evidence that this is the case, but it's hard because part of the challenge in being able to pursue these conclusive studies is that they're inherently limited by small numbers of patients once you start dividing them up into different cohorts based on the underlying fusion partner. At this time in the clinic, we do not make treatment decisions differently based on the fusion partner that's detected.
Great. Thanks, Jess. So who is the typical patient with ROS1 positive lung cancer? Across many studies, it's clear that ROS1 patients tend to have distinct clinical pathologic features, including younger age at diagnosis, almost always adenocarcinoma histology, and a strong association with never smoking. ROS1, like ALK and RET, are really not related to smoking. And maybe I'll pause again just to ask Jess, to share your perspectives, having treated so many ROS1 patients. Do you think this accurately captures the typical ROS1 patient who you may see in clinic?
It does. As I'm sure you'd agree, Dr. Shaw, we see quite a large proportion of young patients that are diagnosed with lung cancer who do have ROS1 fusions in their cancer. And the vast majority of these patients do have adenocarcinoma histology lung cancer, and most have never touched a cigarette in their entire lifetime. And I think it's important for us to remember that there are several oncogene drivers like ROS1 fusions, ALK fusions, EGFR mutations that are enriched in patients who have never smoked before.
Yeah, great. Thanks, Jess. But beyond these clinical pathologic features, I think what really distinguishes our ROS1 patients is their exquisite sensitivity to ROS1 tyrosine kinase inhibitors, or TKIs, which again reflects their state of, ROS1 dependency or oncogene addiction. One of the very first patients who I ever treated on the phase 1 study of crizotinib, and this was now over 10 years ago. This patient had really extensive disease throughout both of his lungs and was extremely symptomatic. And he had pretty severe shortness of breath, even at rest, and also even resting hypoxia. But after just a few doses of crizotinib, his symptoms started to improve. And by about 7 weeks or so, the first scans that we obtained, you can see the remarkable radiologic response that he had. This was a near CR, and also he had complete resolution of his symptoms. And, I think this type of rapid and dramatic response has been seen across all of the ROS1 TKIs in TKI-naive patients. I did want to emphasize one point about ROS1 that can be confusing on the kinome map. And you can see that ALK and ROS1 are actually very closely related. And as a result, many TKIs inhibit both ALK and ROS1. So, for example, crizotinib, ceritinib, and lorlatinib. However, it's important to note that not all ALK TKIs inhibit ROS1, and conversely, not all ROS1 TKIs inhibit ALK. And the most common mistake that I've seen in clinic is with alectinib, because it's so widely used for ALK. But actually, alectinib really has no ROS1 activity. And so I would recommend that if there's uncertainty, just to triple check that the TKI you're prescribing for your ROS1 patient does indeed hit ROS1. I don't know if you want to add or elaborate further here, but I've seen this more than once, and so I thought it was an important point to mention.
Thank you so much. You've really covered the important points. I think it's interesting to take a step back and appreciate how the knowledge and the drug development in the ALK space have really propelled and accelerated the therapeutic advances in ROS1 lung cancer. At the same time, you made a critical point, which is to remember that not all ALK inhibitors are ROS1 inhibitors. And increasingly, with the development of the next generation ROS1 inhibitors, which we'll delve into deeply in the upcoming sections, not all ROS1 inhibitors are ALK inhibitors either. So very important to look at the label and to confirm which drug you're giving to the patients.
Thanks, Jess. Just to again emphasize, these are distinct molecular subtypes of non-small cell lung cancer with increasingly specific TKIs for each subset. Okay, so now let's turn to testing for ROS1. And, I would say that this is really a critical area to understand, because we need to be able to identify those patients with ROS1 so we can direct them to all of these highly effective ROS1 targeted therapies. NCCN guidelines recommend that for all patients with advanced or metastatic non-small cell lung cancer, broad molecular profiling in addition to PD-L1 testing should be undertaken. And that's really with the goal of identifying targets for which we have highly effective targeted therapies. And what I wanted to highlight here specifically is that testing should include even the rare genetic alterations such as ROS1 rearrangements under both squamous cell carcinoma and non-squamous or adenocarcinoma histologies. 5 of the diagnostic modalities that we can use to identify ROS1 fusions in our patients here: FISH, NGS, plasma, cfDNA, and IHC. I'm actually not going to talk more about RT-PCR, since that really is rarely used. And a major limitation is that you really are only testing for ROS1, and you're only testing for known ROS1 fusions. But I would say the other 4 tests are really important for everyone to understand. And so FISH was the first diagnostic developed for ROS1 fusions. It's often considered the traditional gold standard. And as a reminder, this is a break-apart assay, similar in principle to the ALK FISH assay, where we're looking for splitting of the red and green signals to indicate a ROS1 rearrangement. And in some cases, we're looking for just an isolated 3' signal. This is the diagnostic assay that we actually used in the registrational phase 1 study of crizotinib in ROS1 positive lung cancer. However, I would note that FISH is not formally approved as a companion diagnostic. And I would also say that the FISH assay is highly user dependent. The other challenge with FISH is that it's difficult to really establish the exact sensitivity and specificity, but we do know that a few ROS1 fusions can be difficult, if not impossible, to detect by FISH. But probably the most widely used test for ROS1 fusion nowadays is next-generation sequencing, or NGS. And I would say that NGS is, in fact, the preferred test for ROS1 rearrangement, and it does enable testing for multiple biomarkers in a single test. 2 NGS assays are now FDA approved as companion diagnostics for ROS1 TKIs. That's the Foundation-1 CDX assay for entrectinib and Oncomind's DX target test for crizotinib. And I would note that it's important that DNA-based next-generation sequencing can also be done using circulating tumor DNA, or ctDNA. And these liquid biopsies have been shown to be able to detect ROS1 fusions, and in some cases, really enabling the rapid identification of this target before a tumor biopsy or tumor testing has even been done. But liquid biopsies can also be challenging because they can have lower sensitivity. I think many of you appreciate that the extent and the location of the disease can impact detection of ctDNA, and some tumors just don't shed as much tumor DNA into the circulation. And so given the known lower sensitivity of liquid biopsies, I would say that if a patient is negative for ROS1 by ctDNA, so negative in liquid biopsy, additional testing and ideally testing of the tumor tissue is really needed to be certain that there's not a ROS1 rearrangement. Actually, maybe I'll pause here just to ask Jess again to comment, because, I think we see increasing use of liquid biopsies at the time of diagnosis even. And I was wondering if you could share your experience using ctDNA to identify ROS1 fusions in your patients.
Sure, happy to do that. We have been using ctDNA increasingly for patients who are diagnosed with metastatic lung cancer because they do offer certain advantages. The one about liquid biopsies being less invasive compared to tissue biopsy, this is a key advantage for patients. And also often the plasma biopsies with ctDNA can offer a relatively faster turnaround compared to tissue next-generation sequencing at many centers. So in my clinic, we actually send liquid and tissue testing in parallel at the time of diagnosis of metastatic lung cancer. That said, I did want to underscore the point that you made, Dr. Shaw, that ctDNA can be non-diagnostic because of insufficient tumor DNA shedding. So if it's negative, again, I would reiterate, we do not stop there. It has to be confirmed then by tissue testing.
Even testing of tumor tissue, though, using an NGS, DNA-based NGS assay can miss some ROS1 fusions. And so for ROS1 and other rearrangements, actually RNA-based sequencing is often preferred. RNA-based anchored multiplex PCR using this Archer DX assay was first developed by John Iufredi and his colleagues at MGH. And in one study, it was shown that non-small cell lung cancers where DNA-based NGS testing was negative for targetable alterations, when they used targeted RNA sequencing, that assay was able to identify targets in 14% of cases, and that included ROS1 fusions. So I definitely do favor RNA-based NGS for definitively identifying ROS1 and other fusions in tumor samples. I'm curious just if you feel the same way here about sort of RNA versus DNA-based testing for fusions.
I definitely do. A number of studies like this important one that you just shared have shown that RNA-based NGS is the preferred method for detecting ROS1 fusions and other fusions as well. It's just more sensitive than DNA-based NGS because the RNA-based NGS allows us to try and overcome some of the barriers having to do with the long introns and repetitive element sequences in the DNA. And so it's very important to consider RNA-based NGS if the DNA-based NGS is done but does not show any actionable oncogene alterations.
Okay, so then maybe the last diagnostic that I'll just mention is IHC, or immunohistochemical detection of ROS1. Here we're looking for expression of the ROS1 protein. And we do know from many studies that ROS1 rearranged cancers can show diffuse and moderate to strong staining for ROS1 protein by IHC. But the challenge here is that ROS1 can be expressed in non-small cell lung cancers without, so these don't have ROS1 rearrangement, although in these cases, expression tends to be weaker and more focal. Nevertheless, I would say that IHC for ROS1 can basically overcall, and so specificity is lower than other assays. And so any positive result by IHC really needs to be confirmed by another testing modality. And as I've noted here, ROS1 IHC is not an FDA-approved test for ROS1 rearrangement. And so just to recap, I would say understanding how to test for ROS1 rearrangement is extremely important given that ROS1 is so well validated now and there's so many effective ROS1 targeted therapies available. All patients with metastatic non-small cell lung cancer, as I mentioned, should undergo ideally multiplex testing for targetable alterations, including ROS1 rearrangement. And then of the multiple testing modalities available, NGS testing of tumor tissue is preferred over FISH or IHC. Liquid biopsies can be used, especially if tumor tissue is not available. But as I mentioned, liquid biopsies can miss ROS1 fusions. And so negative results should be followed up with a more sensitive test such as NGS. Finally, just to note that some institutions, including my own, do use ROS1 IHC as an initial screen for possible ROS1 fusion. However, as I mentioned, IHC does have lower specificity, can overcall positive cases, and so a positive IHC result must be confirmed by next-generation sequencing or FISH.
Thank you, Dr. Lin and Dr. Shaw, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, ROS1 Revealed, a cancer conversation on the changing tide of non-small cell lung cancer treatment, and to download the slide set associated with this discussion, please click the link in the show notes. Thanks for listening.